Okay, hello everybody. My name is Dr. Jo White. I'm a clinical psychologist and advanced certified schema therapist, and I'm really happy to be here today with two guests who are going to talk with me about their therapeutic approach Speaks for anorexia, and I'm really excited to hear more about the model. So first off, would you like to introduce yourselves? So Anna, do you want to go first?
Yeah, so I'm Dr. Anna Oldershaw. I'm a clinical psychologist and also a reader in clinical psychology. I currently now work at the Salomons Institute for Applied Psychology, and I did back in the day in 2006 did a PhD in eating disorders, and that began kind of my experience working in eating disorders. I'm also an accredited schema therapist, and I'm an emotion focused therapist, supervisor and trainer, and I run the Emotion Focused Therapy Institute of England, which runs out of the Salomons Institute for Applied Psychology.
Great.
So I'm really happy to be here. Thanks for having us.
Thank you, Anna. Helen?
Thanks, Jo. Thanks for having us. I'm Helen Startup. I'm a clinical psychologist, and I currently co-direct schema therapy training school called Schema Therapy School. Alongside this, work in my own private practice. Previously, I've worked for about 20 years in the area of eating disorders, across various services in London and Sussex. And was kind of lucky to be around at a time when new treatments were being developed. So I was involved in the mantra treatment, the Maudsley anorexia nervosa treatment for adults, and thinking about its sort of translation and rollout, and a little bit about its evaluation. And prior to this, I did a PhD on sort of processes, cognitive processes relevant to anxiety. And again, have been sort of interested in, really thinking hard about the sort of needs of people with eating disorders, really, and how we can, best translate different therapies to improve outcomes. So, yeah, thanks for having me.
Great. So much expertise between the two of you. Eating disorders is not something that I specialise in, but lots of my clients will present with some eating disorder issues. So I'm really looking forward to learning more from both of you this evening and getting a taste of the Speaks model. So we've got a few questions, and I think our first one is really, how did you come to develop the Speaks therapy?
I guess that came out of work that we'd done previously, which was in my PhD, was looking at social processes and also emotional processes, and a recognition that people with eating disorders, people with anorexia in particular, really struggled with emotions and struggled with being able to access emotions, being able to use emotions in useful ways in their lives, and then became really avoidant of emotions and often quite disconnected from their emotions, which left them quite disconnected from themselves. And so thinking really about, okay, so how do we work with that in therapy when, we're so often working at more of a cognitive level? Maybe we need to bring in something a bit more experiential. Helen and I had met back in about 2005, I think. Helen, was it? A long time ago. And we both sort of had, I guess Helen can speak for herself, but this sense that maybe we could look at these things a little bit differently and look at some of the emotional processes or the ways people get stuck. And particularly when you're still working quite cognitively, people might get quite stuck. So how do we get people unstuck and help people to move forward in their lives in more effective ways or more helpful ways for them? So we kind of came together and applied for some funding and to develop Speaks. And we developed it really wanting to develop it from the bottom up. So at the time we developed Speaks, I wasn't trained in schema therapy. I wasn't trained in emotion focused therapy. I just really wanted to get a sense from people who'd recovered from anorexia in particular, what had changed for them and how did they feel that change had been facilitated, so that we could build a sense of a process of change that we might want to facilitate in therapy. And then after that, think about, okay, and what therapeutic models or what therapeutic techniques or tasks would most helpfully facilitate this in a therapeutic approach. So Helen, I guess you can say a bit more about how you came to it as well, or your thinking when we first started Speaks.
Yeah, so I think it's just to reiterate. So as you say, Hannah, we met many years ago and we sort of had real overlapping interest in the idea that emotional processing and just sort of broader relationships with emotions and the self were really important and central to eating disorders, really. And, you know, although have been spoken about in different ways in the literature, there's a sort of recognition, I think, or a sense that we had that it's not just about noticing what's needed, but thinking about how do we actually translate this into therapeutic ways of working that are effective for people, that people can sort of use in a way that's helpful to reach the outcomes that they want to reach. And, you know, it was at a time when I was training schema therapy. I was a schema therapist at the time and running schema therapy school actually at the time. And sort of, you know, really value the schema model in terms of thinking about eating disorders. You know, I still think there can be a sense of, well, we know emotional change is important. We know accessing vulnerability is central to this way of working, but it's not always well articulated exactly how we bring about that emotional change. And I think that was really sort of foundational to thinking about speech. And as Anna said, you know, very much a sort of bottom-up approach. So not trying to bring a sort of whole load of preconceptions to the treatment development, but very much, you know, speaking to people who've recovered, who have eating disorders, carers and therapists, and finding out, you know, what people think is important and valuable and going from there, really.
It sounds like an incredible amount of work and time and thought has gone into developing this model, and that you two have been working on this for a very long time.
Yeah, I mean, it was sort of a 5-year research program, so 2 years of intervention development, as Helen says, speaking to lots of different groups of people, people who are currently still unwell, people who've recovered, therapists, family members, really trying to learn as much as we could. And then we did a 2-year feasibility trial in the NHS in the UK, in 2 NHS trusts, to look at the rollout. Could it be delivered? Could it be delivered in the way that we think it can, in the number of sessions? And what do people think about it? So this, you know, and also then testing out this hypothesized change process that we had around how to facilitate getting people to the place that they said they wanted to get to, which people described as the real me. So having this sense of kind of connection with themselves and being able, a more integrated sense of self, where they weren't getting stuck in, you know, in schema sometimes in, you know, in a coping mode, but able to usefully direct themselves in their life and taking helpful emotional information to move forward in helpful ways in their life. So that was kind of our starting point, that people were saying, well, this is, and we realized people were very disconnected from that. And so it was like, okay, so how do we build this? How do we help people get there? And I guess anyone listening who knows about schema therapy can probably already get a sense of how schema therapy is useful for that, and how that the theory behind schema therapy links in.
And I was remembering the other challenge, Anna, was just at that point was the pandemic and lockdown, and then thinking about, you know, all ready to roll out for the feasibility trial in terms of an experiential therapy and live sessions, and then obviously having to translate that to purely online work. So, you know, lots of different challenges over a long period of time, but, you know, that's what it's all about, I guess. Exciting as well.
You two have got real perseverance. Yeah. So can you tell us a bit more about the therapy, about what speech therapy kind of looks like?
Yeah. So Speaks is kind of, it's a phased approach, it's process oriented. So it's thinking about the process of change. We start off with a kind of schema mode model. I don't know if you want to say a bit more about that, Helen, and then,
so it's probably sort of very, you know, familiar to most, but we would draw out a mode map depicting, you know, the sort of classic modes that we may encounter in eating disorders. So we would have vulnerable child, or we call it in Speaks the sort of little self, the various coping modes that are preventing access really to the vulnerability, and a critic of all sorts of varieties. And then very, very important to Speaks would be the healthy adult. And, you know, the idea that much of the goal of Speaks really is to have better connection between the healthy adult and the sort of emotional material and unmet needs really of the vulnerable side, and for that to be able to be used really as a guide more in life. But what's sort of, you know, particularly sort of playful about Speaks and adds, I think, massively to the formulation is using toys in the formulation process. So, it's not for everyone, but a lot of people really sort of enjoy the process of being able to choose a toy that represents a particular part of the self or a mode, and it can sort of give it a sort of almost like embodied, sort of more creative description and account of particular parts of the self, and also speaks to the dynamics we know of modes. It's not about modes being static, but mode relationships, and objects can be used in a really nice way to depict the qualities of modes as well as those mode relationships. So that early phase, very much building the relationship, mode mapping in this kind of quite dynamic way, and with a particular emphasis on thinking about the healthy adult and the sort of importance of that really through the therapy journey. It's phase one.
Yeah, and I'd say, also the therapeutic relationship, another thing common between schema therapy and emotion focused therapy is the therapeutic relationship is seen as core to change. So, limited reparenting, and also in emotion focused therapy, there's been a lot of research around how we as therapists might talk with our clients and how that might facilitate emotion regulation or emotion deepening. And so, a lot of research on sort of things like conversation analysis and things like that to really thinking about building that relationship, being attuned as a therapist, and the limited reparenting, and using toys or objects or just, anything creative to sort of really bring in a more dynamic aspect to the parts of self and help people explore them, because people with anorexia often can be suffering with difficulties like alexithymia, struggling to put words to things, and it just gives another way to explore it with people, even down to the sort of the size of the toy or the object, or and then getting people to map them together, what's close, what's far away, what gets in the way of what. It just gives a different way of kind of working with things. And then we move on to thinking about what people talked about was very important early on, was seeing through the facade of anorexia. So realizing that, this tells me it's here to help me in my life, but actually this is part of what's keeping me stuck. And this is also feeding into some of my ways of coping, or maybe feeding into some other aspects of my presentation as well. So being able to start to see through the facade and increase motivation for change. So, early on, we would also be looking at some kind of initial behavioural change around regular eating, and through seeing through the facade, that gets facilitated even more. So people can start to, so that might involve chair work. It might involve some chair work with modes to try and sort of bypass some of the coping modes, chair work with the eating disorder critic to try and work with that, try and sort of quieten down that a little bit, maybe help that soften a little bit by helping it to understand the impact it's having on the person and their life. And really trying to help the person to get to a place where they've been able to get past some of the blocks to be able to access a bit more processing and really get into the change phase of therapy. So that would be sort of the second phase, trying to get people in. And then the third phase is really about trying to help people get, I guess, essentially to that core pain and unmet need, and work with that in therapy. And so, that sort of working with the eating disorder critic is a way to really access a broader critic, that it's not just there's something wrong with my body, but there's something wrong with me, with who I am, I'm fundamentally inadequate. So we try and access the broader critic that way. And then we can start to think about the core pain, because that tells us a little bit about what the vulnerable child might be feeling. And in emotion focused therapy terms, that's quite often thought of as a bad stuck old feeling. So it's a feeling that's quite easily triggered in my life. So shame, for example, and is often a poor fit for the current situation it's been triggered in. So, that's really the feelings of the vulnerable child, and then associated with unmet needs. So we start to access that and start to work with that in that sort of change phase. And really, we're trying to transform those stuck old emotional patterns so people can start to access self-efficacy, self-agency. So it might be shifting from feeling shame to being able to start to feel some kind of helpful anger, assertive anger around the fact that actually I didn't have my needs met and I deserved to. Being able to start to access that and move towards that, which can then help people move towards self-efficacy and self-agency, and use those emotions can be more usefully used. The shame's not helpful to me, but those emotions can be, and maybe grieving the loss of what I would have liked to have happened to me when I was a child. So working with those, and then, you know, not everybody accesses emotion in this really deep experiential way. So it's still trying to work alongside that. You're also constantly moving backwards and forwards between sort of emotion, the cognitive and behavioural, keeping the eating going as much as you can, and also connecting the head and the heart. So it's the meaning making, the meaning bridges between the emotion and the cognitive, and working on with the cognitions as well. And then we move to phase 5, which is consolidation of the real me. And that's where you might be working a little bit more behaviourally and working to really consolidate some of those changes that are starting to emerge in the person's life, really encouraging those, prizing those, and really working towards the person being able to be guided by themselves in their life now, and to live their life in the way that they want to, rather than being guided by the eating disorder, which is keeping them stuck.
Thank you. That was very comprehensive.
Is it long? Sorry.
No, it was great to have all of that detail. I was thinking how many sessions typically is it sort of, I'm sure it's not manualized, but is there a framework in terms of how long?
There is, it is manualized in a way. We call it a guidebook. So there's a change process, and then we have suggested tasks for each phase that we think will facilitate the mechanisms of change associated with that phase. So we call it a guidebook. You know, therapists often come to this with a lot of skill in terms of eating disorders or other models. So we ask them to bring their clinical skill and pull on what they know, whilst also highlighting these are the, you know, the phases of change and the order in which that we think that they mostly happen in. We recognise people move backwards and forwards as well between those. I've forgotten what your original question was, Jo.
I was asking about time frame. Is there
a time frame?
set number
Sorry.
of sessions?
Yes. So on average, so in the trial, on average, people had 40 sessions. And I think standard deviation was 12. So some people had a little bit more, some people had a little bit less.
Yeah, and it's all individual sessions?
Individual sessions, yeah, usually weekly as well. And there was quite a lot of complexity in terms of the people who came into the trial. So really it's people who've been unwell for longer periods of time. So I think the sort of average duration of illness was about 9 years. And there was quite a bit of comorbidity in terms of sort of personality disorder type presentations or trauma, complex trauma.
So it's not a overly long period of time, is it, considering the complexity then that you've been working with?
Yeah, I think so. Yeah.
It's about what you would expect, or maybe less. So how do schema therapy and emotion focused therapy come together to form Speaks?
Yeah, I mean, I guess I might have answered some of that in my comprehensive answer to the last question. But yeah, I mean, it's really thinking about, you know, when you get to that emotion change process, I think emotion focused therapy does bring something to schema therapy. For me, when I'm working in terms of deepening to emotion change processes, it gives me more skill to do that, particularly for people who get very stuck in their head and it's very hard to take them to vulnerability. I feel like I have a lot of skill from the EFT side of my training that enables me to do that and really help people to land on emotions and then to be able to work with them and transform them. Emotion focused therapy has a lot of theory around emotion transformation and how we change emotion, changing emotion with emotion being one of those kind of ways, you know, in which it argues that we get from stuck emotions to more productive emotions. So I think emotion focused therapy, when you're in that stage of things, really brings something in particular in terms of facilitating working with core pain and unmet need. And of course, you know, some of that comes out in schema therapy as well, you know, in some of the schema therapy tasks where you are working with core pain and unmet need. There's a lot of overlap there as well.
You've just added another CPD to my list now. When can I find EFT training? When can I put it in?
I would love to have you, Jo.
Sorry.
Yeah,
Helen,
I think just to add to that, I think the sort of I think so the richness of the sort of conceptualization and sort of tasks really that EFT bring around emotion have definitely sort of changed aspects of my schema therapy practice, particularly, the recognition that, a lot of the time when we talk about emotion, what we're actually talking about is secondary emotion, emotion about the link to coping modes ultimately. So, getting stuck in talking about people's struggles with eating or over exercising and how that leaves them feeling, rather than whole therapies can be spent stuck at that level, rather than the recognition that actually we need to deepen and get below that. And that's where we get the primary emotional states, and that they can be really quite different. And I think, again, there is real value in a presentation that has, almost universally, people will talk in different ways about struggles with emotions and painful relationships with emotions and painful, sometimes historical attachments that have involved difficult emotions. And I think, speaks is many things, but it has an emphasis on an emotional change process. And I think there's real value as a therapist to being able to follow something which has a sort of clear emphasis with many different ways of working, many that are, I think, deeper because of what EFT brings to the approach. I think they blend well, and I think being anchored on a mode formulation is kind of like the bones of the treatment in a way, which is as we know, very much the sort of bread and butter of how we work in schema therapy. So it's I think it sort of comes together in a sort of sensible and meaningful way that fits with our understanding, really, and sense of this client group.
Okay, so how do we learn more about Speaks?
Okay, well, we've got some information on a website people can read about. There's quite a few papers out already. There's going to be more papers. A lot of them are open access. We have some Speaks training coming up in November/early December. So it's to keep reminding myself this, the 28th of November, the 30th of November, and the 1st of December. It's a 3-day training and it's online. And there we really cover, we don't go into some of the basics around working with people with eating disorders, that might be a lot more available, say from CBT training. So things that you do need to do still, like getting people eating regularly. We don't cover that, but we really focus in on what we're talking about here around that emotion kind of change process, or just the therapeutic change process, what that looks like, what the evidence for it is, and how you might facilitate that, and focus on some of the core tasks that we think most helpfully facilitate that change process. So it's really experiential training. We use videos, lots of skills practice in small groups. So, I mean, I always love it. I always find it fun. But yeah, so that's coming up. And I think the 30th of September is when the early bird runs out. So it's another couple of weeks on that. And that can be booked, but I'll put a link in the notes about how to book onto that.
Yeah, come and join us. So it's, be a lively, as Anna said, experiential few days, chances to practice, chances to observe, take you through the whole sort of different stages, the different treatment aspects. So it'd be lovely for people to join. Yeah,
and I think be of interest for people who are not just working in eating disorders, but who are interested in maybe how would you blend a bit more of the emotion focus into my schema therapy practice. And also working with stuck presentations, that's a feedback we've had before, is actually just quite broadly useful for working with people who are quite stuck, even if it's not with an eating disorder. So hopefully can appeal to a range of people as well.
Sounds great. Sounds great. And there was a lovely resource that I know that I think I signed up to your mailing list and received a really nice resource around formulation. Can we put a link to that in the comments as well for people to get hold of that? I know everybody likes a free resource. Oh, thank you so much, both of you, for coming and
having us. Yeah, thanks, Jo.
Thank you for sharing your knowledge with us. It's always, that's why I always love doing these interviews, because I get to hear about so many interesting things that people are up to. So thanks again, and we will see everybody soon.
Yeah, thank you.
Thank you.